Okay, so good morning, everybody, or afternoon, I guess. Just going to throw up our PowerPoint. Let's see how this goes. Okay, everybody. So happy Thursday. It's 3 o'clock, and we're here today to talk about the impact of COVID-19 on respiratory home care. So I do have with me today two speakers from ProRest that I'll introduce in a minute. So I have Dave and Stephanie, and they're going to be discussing the impact of COVID-19 on respiratory home care. So just a quick hello. So we do have our RTSO board and our voting and non-voting members. So if you've been watching a few of these, you've seen this slide numerous times, so I won't go through everybody's name, but we're all working extremely hard and we're extremely grateful for all the great work that you're doing out wherever you are, whether it's in the community or in the hospital or somewhere in between. For sure, this pandemic has been focused on respiratory issues. It has brought to light all kinds of different challenges, and I want to thank and acknowledge the work that everybody's doing as we move through this. Another initiative, just an example of how resilient RTs are, is that during all of this, Southlake went ahead and they raised some money for food banks in their area. I think this was about 2 to 3 weeks ago now. And then they challenged everybody else throughout the province to raise money as well. So they started this and posted, and they put it out as a hashtag of HCWS for food, which is Healthcare Workers for Food. And since then, we've had numerous RT departments across the province step up. So we did have in the Mississauga area, we had the RTs and AAs that went ahead and raised $2,068, which is amazing. We had Sick Kids that was able to raise $2,812. St. Joe's in Hamilton was able to raise $23.90 for their local food banks. And then last night it was posted that the Oakville, Trafalgar, or I guess Halton Health region was able to raise, I think it's $2,500 or in that range, which is amazing. And I also know there's fundraising initiatives going on at Sunnybrook and Michael Guerin. And anybody else who's doing it, you're doing a great job, and feel free to post it somewhere on social media with the hashtag of HCWS for food. And then Ontario RRT Support is the Facebook group where we've been posting them up as well. So if you are a member of Facebook, feel free to try and join that. It's not run by the RTSO, but we are part of it. So we are for sure sharing really great news stories through that. So just along the side of great news stories, do you want to recognize the work of everybody throughout the continuum of care? So we do have a couple pictures that have been shared across social media from various hospitals of various RTs sporting various levels of PPE, as well as a really amazing thank you video that came out from one of the daughters or classroom members. So there's a thank you poster there that she made for her mom, and it got put in a video thanking healthcare workers. And then last week, ProRest went around to some of the hospitals, and they were putting out nursing, thank you for nurses, but also recognizing the rest of the frontline workers, and then all the pretty rocks. So our work is being recognized throughout the province. Everything that you're doing is being recognized and valued, and thank you so much for everything that you continue to do. As the president of the RTSO now, I am very grateful to be working with such a great group of people, and I'm constantly inspired and moved by all the wonderful things that are being done during a very stressful time. So without further delay, I would like to introduce our speakers for today. So we do have Dave Jones. So he's a registered respiratory therapist with ProRest. He was also at Inspire last year, and he won the door prize to the CSRT. So that's exciting. I'm not sure what's happening with that though. He's been a respiratory therapist for over 20 years, working initially in acute care before moving to the community, and has spent the past 15 years in leadership roles with ProRest. Dave has represented respiratory therapists at both the provincial and national tables through his previous position as the president of the CRTO. He's a regional manager at the corporate clinical practice lead for ProRest, mentoring and leading the respiratory therapy team in innovative chronic disease management and complex respiratory care projects within the Southwest LHIN. Dave is most passionate about professional practice and clinical competencies, ensuring quality patient care across all parts of the healthcare system. And then joining Dave today, we also have Stephanie. And Stephanie is a member of good standing of the College of Respiratory Therapists of Ontario and is a graduate of the Michener Institute for Applied Health Sciences. She started her respiratory therapy career as a staff registered therapist at the University Health Network, Toronto General Hospital, where she gained experience in acute care and then founded a small business where she acquired management and business development skills. This experience prompted her to pursue a career in business development and clinical leadership with ProRest, where she found challenge and professional growth and development for the past 18 years. Stephanie's been a longtime volunteer of the Ontario Lung Association, supporting the Ontario Respiratory Care Society with local initiatives. And Stephanie provides mentorship and leadership to the ProREF's Northern Ontario operations, focusing on enabling a culture of optimizing patient care experience. So without further ado, I'm going to go ahead and hand the screen over to them so that they can share their experience and knowledge with us. Did you get it, Dave?
Hey, I did. Thanks, Kelly. Hopefully my screen's popping up for people.
I see it.
Maybe. There we go. So hopefully it's working. So first, thanks to Kelly and the RTSO for hosting us and for asking us to do this. It's a great opportunity to just kind of give a brief background of some of our work in the community during this this whole pandemic. So I will start off, chat for a few minutes about things, and then I'll hand over to Stephanie to continue on the conversation. If you have any questions as you go through, I think Kelly may have mentioned already, we've chatted about it a couple times, so you can enter questions, and then at the end we'll address those questions and try and answer them for you. Hopefully we can get complete answers for you, and if we can't, then we can go off and try and find a better answer for you. So just a few key things we're going to talk about. First, just oxygen therapy during this whole time, positive airway pressure or CPAP therapy, and then the more complex respiratory care happening in the community. Sorry, I'm staring at one screen because that's where my camera is. My normal screen's off to my side, so I apologize if I squint the odd time. My computer's got a small screen or my eyes aren't very good. I'm not sure which. So a brief timeline for us, and this is similar to a lot of people out there, that early January, we were starting to monitor Health Canada, Ontario Health, Public Health, LINS, all kinds of different news sources that were starting to identify at that point the novel coronavirus, not even named COVID-19 yet. But the bigger part for us was really getting that message out to our teams to be aware of this, to watch for this, so that when our clients or our patients were asking questions, they were aware of it. And the other big thing at that point was just the reinforcement of hand hygiene. So again, making sure that everyone was being very conscientious about that. It seems at some points as you go through that some things kind of slip a little bit, and so just making sure that that was a high priority for all of our teams. We have a pandemic plan in place. It needed some updates to match this new pandemic, but getting that done. And then as well, our PPE supplies. So we always have some supplies, but making sure that we had what we needed to manage during this process. As well, fortunately, many of us are respirator fitters and N95 respirator fitters, so we are able to fit our own teams, because part of our role in our community work is we fit a lot of other care providers in the community as well. So we work with a lot of our long-term care homes, retirement homes, things like that, to not only ensure that they have their staff fit, but also to train some of them how to fit others so that they can continue on with that process, so we don't have to do it all the time. The next big stage, of course, was the screening process, not only our team members, but also all of the patients that we care for. So really starting the end of January, getting new screeners implemented, and as everyone's seen, the massive evolution in that process, finding that daily or every few days, those screeners were changing, the questions were changing, the geographies were changing, all different kinds of things. And in fact, on the side of the screen right now, you can see our current screener, and that was updated last night and this morning, so that it still continues to change as at this point more of the secondary effects and secondary symptoms are noted with a lot of people, but also just refining things, making sure that all the effective pieces and the process to follow when any of those screens are having positive results. And then the other thing that we were really seeing at that point, January, February, even into March, was the application of guidelines and independent creation of guidelines. So whether it was the long-term care home that were taking what the published guidelines were and feeling like they were going the extra step and adding some components to that. So we had places where everyone was using 14 days as their guideline, their travel guideline. And we had a few homes that for some reason decided to use 21 days. So it's just some uniqueness with things like that, but making sure our staff were aware of those uniquenesses and corresponding what they had to do to manage with those different things. Long-term care, we're creating different rules. Retirement homes were not always having the same rules as long-term care. They were able to utilize the guidelines for long-term care, but they didn't always have those same rules, so they were applying them in different ways. So we are seeing that variation, and so that created some additional work for our teams as they were going into homes, but it also created the necessity for us to be there and understand why there were differences and be able to explain those things for our teams and for our patients as well. Then moving on, as we moved into March, World Health Organization declared the pandemic on March 11th. And from then, we're still seeing, that evolution of all the screening, of all the restrictions, of the guidelines. And then the next part for us was to ensure that we were on the essential service list, to make sure that we weren't an oversight, to make sure that we would continue working and caring for our clients. We'd already been concerned, the other term that they were using were essential visitors, and that was the term for long-term care. So we already had been confirmed that we were essential visitors for our long-term care homes, meaning that we could still get access to those homes to provide care and provide services there. But for the whole province, we need to make sure, unfortunately, that was confirmed for us on March 23rd so that we can continue providing that care, like I said. So the key roles we really saw throughout this whole thing and as it evolved, first priority, care for our team, keep them safe. If we don't have our team members, if we don't have our respiratory therapists, our service delivery representatives, customer service people, if we don't have all the members of our team, we really can't work very effectively. Excuse me. Sorry, I should learn to hydrate better before I talk. So the key roles for our team, keeping them safe. And then the secondary thing that we were seeing as the hospitals were starting to decant, they were doing it as rapidly as possible, which most of you are aware of and see firsthand. But those patients were needing oxygen. We were seeing patients that were having very complex respiratory needs being sent home potentially ahead of when they were scheduled. They weren't people that were likely going home that wouldn't have gone home otherwise, but they were going home earlier than what we had anticipated they were going to go. And sometimes that meant, so some of the background preparation was getting minimized. So we were doing a lot more things on the fly to keep these people safe. Next thing was to keep our current patients at home. With the pressure to keep the hospitals, to get them empty, to create space, to create capacity, we wanted to make sure that the people that we're caring for at home, whether they're on oxygen or any other home respiratory therapy, we wanted to make sure that those people were able to stay home and not need to visit the hospital for anything that we had any ability to support. We wanted to ensure that there was safe and effective care for the highly vulnerable population. We're dealing with, when you look at the risk factors with COVID and with any ARI, we're looking at the elderly people, the people with chronic lung diseases, all those different things, and the immunosuppressed. Well, that's a large portion of who we're dealing with, and that's what makes us essential to care for that population. So we needed to care for them. We needed to actively make that decision that we were caring for these people and servicing what their needs were. We also had to prepare to accept the discharges, or not even the discharges, but the diversions of the COVID-19 positive people. So someone seen and emerge, rather than admitting them, there were hospitals in different areas looking at how do we manage those people without ever admitting them to hospital. So we were preparing for that. And then the other reality that came up were all the non-traditional care sites. So the field hospitals, the different areas. And so we were getting calls from hospitals, from other people organizing these non-traditional care sites, looking for resources, both human resources and equipment and advice on how to do it. What were the options? What could they do to make these field hospitals functional and to serve the population they were anticipating that were coming to them? So a lot of our people, obviously the people on oxygen, were dealing with the assistive devices program and the home oxygen program. So based on the other dates, we're seeing now the home oxygen program, it started to introduce some temporary changes a little bit after a lot of those other things happened. They were waiting to see what happened, what was implemented, and then they were able to implement some changes. So one of the first things they implemented was that COVID-19 was actually an acceptable diagnosis for oxygen at home. Makes sense. They introduced a few other things and kind of in small steps. So they waived the need for blood gases, but they still required that we had a letter from the prescriber stating why blood gases weren't an option at that point. Long-term funding renewals. So everyone on oxygen at home, we have some renewals through the first year, but then every year after that, we have to renew those people. And they decided to put all those on hold and just say, yeah, let's wait on all those renewals. You can continue to provide oxygen, but don't worry about renewing those people right now. And then new people requiring oxygen in long-term care didn't necessarily need a visit by a respiratory therapist. So some of the homes, even though we were classified as essential visitors, they were really trying to minimize the number of people coming into the homes. So when we were able to talk with the director of care, in some cases, we wouldn't need to go in and see those people. We could rely on the fact that the healthcare providers within those homes checking and making sure things were set up right and safely for those people. So those requirements expanded over the next little while, I guess the exemptions expanded over the next little while. So then the home oxygen program decided that renewals did not require assessment, so that for our therapists in the community, they didn't actually have to go in the home and get an oximetry recording to demonstrate that the person still needed oxygen at this point. The initial qualification oximetry in the hospital, where we're not getting blood gases, but even if the hospital staff didn't have a recorder for their oximeter, which most don't, that we're able to accept just a noted authorization from that nurse RT in the hospital saying, yeah, I recorded SATs and their oxygen level was 85% on room air. And that's all that was required. They had to sign off on that. And then the next piece was the in-home training by the respiratory therapist, which is one of our requirements right now, or generally, is that we're in and we do the in-home training and really focus on safety and education with the people. And if you could do it without being in the home, without any risk to the patient, you could not do that. You could avoid that in-home visit piece. Some of these pieces we did implement, others, like in this case, this one, we didn't. We determined that realistically as therapists, two things. One, we could be safe going into the person's home using appropriate PPE. And two, we didn't feel that we could fully assess these people without actually being there to physically assess them. And part of it was the assessment of them. Part of it was the assessment of their living space to make sure that they were safe, because that's a huge piece of people being at home safely with oxygen. So we continued to use our therapist, and I'll talk a little bit more about that in a few minutes. The other things that ADP implemented, the prescriber prescriptions were accepted without a signature on the forms. You just still needed a prescription, so a little bit different process there. And one of the most notable ones, though, that positive airway pressure system still required the regular level 1 sleep studies. So there was no change really in CPAP requirements, other than the fact that most of the CPAP sleep labs had been closed down. So they had closed their systems because they couldn't do it safely. They didn't view that they were absolutely essential at that moment. And so they were not performing those polysomnographies at the time. And then by the beginning of April, we had a few more changes. The home oxygen program actually completely waived medical eligibility criteria. So they just said, if someone determines they need oxygen, meaning a physician, nurse, practitioner, then we can start home oxygen. We don't need to have blood gases. We don't need to have oximetry. We can just proceed with setting up oxygen for those people. And the other piece, that all the renewals, so it didn't matter when the person started oxygen, if they had a renewal due, it was postponed till the end of summer or the end of August of this year. So those two were the kind of the biggest magnitude of changes for us from the home oxygen program. So what we had to do, we had to obviously, all the rules with ADP, we had to follow the rules, follow their guidelines, but what we need to do for our patients. So we established very early on, we established what we called COVID-19 teams, or they got a few different names, but essentially we had a couple people in every office, a service delivery representative, so one of the people that delivers the equipment, and one of our respiratory therapists were specifically practicing and preparing to care for anyone that came home with presumed or with confirmed COVID-19. This process worked well in the early days because we really didn't have that many people coming home with it. The biggest challenge we had was, well, these people didn't want to be on call all the time, which is quite reasonable. So we had to figure out a system that actually accommodated on call, and in the circumstance where we might have multiple people going home at a time, then they couldn't be everywhere either. So we needed to expand that training so that all of our team were comfortable. Our respiratory therapists, they were all comfortable with PPE. Yes, it was good to do mock trials and practice to ensure that everyone was doing it properly, and some good coaching with that. But we needed to make sure that all of our team were very, very proficient at using their PPE safely and providing that service. We had to implement some physical distancing measures in our offices and vehicles. So we have some processes that just by, either it's more convenient or by the size of the equipment that we're moving, we have two people going to do some things at people's homes. Well, now we would have to send two vehicles to do that so that they'd be able to do that safely. Making sure that in our offices that everyone had their own space, that they could keep that physical distance, so that we were following the guidelines and there was reduced risk for them. We also had to plan for what staff isolation would look like, because we knew that some people would likely get exposed either in their personal lives or through work. So we had to plan for that. And we have small teams, so planning for that meant, how do we manage if one person has to be away for 14 days? How do you manage to keep all the work done without having those people around? And as well, the staff absences due to childcare or other regular illnesses. We knew that this wasn't going to stop any of the other illnesses, so that it meant we had to plan for all those extra things. We also had to rethink how we did most of our routine work. Being in the community, we're in people's homes all the time, and you're in multiple homes every day. So we had to figure out how we could deliver, make sure that people had what they needed, and care for them without being in their homes. So we were very early in the contactless delivery systems. A lot of our service delivery representatives refer to them as porch deliveries. And so it's just, they're figuring out that process and making sure that people were comfortable with it, and that people could, bring the equipment into their homes themselves, different things like that. And then, of course, the continuous patient and staff screening. So we have not only our internal screening, but every person that we were going to see, either our customer service were screening them, or the person going to see them, they were being screened every single visit. So it was some extra touch points just to make sure that everyone was being safe. We also had to postpone all the non-essential stuff, which really for us in large part meant the tests like nocturnal oximetry, and those people with routine CPAP prescriptions that haven't had them filled yet, or just had their sleep study and haven't moved along that process yet. So those processes all got postponed for now. And then one of the benefits in working in the community, we have a very proactive company. And so our company implemented, they called them COVID-19 days. They weren't very creative in the naming process, but they were additional days. They weren't people's vacation days. They weren't sick days. They were specifically COVID days for childcare reasons, for whatever they happened to be. But we had an extra pool of days available. So that really helped our staff and helped our team be able to manage and to deal with all the life outside of work very effectively while still continuing to work. The other big piece, we had to source a lot of equipment. We had a good supply of PPE. All of our staff were N95 fitted, like I mentioned earlier, so that we were in good shape there, but our PPE supplies weren't endless. And I don't think anyone had an endless supply of PPE, but we were in a bit of a different position. We weren't the hospitals. So the hospitals had, you know, other people like the government, things like that, that were trying to source extra supplies for them. In the community, we're pretty much left to our own devices to go through our suppliers to find resources. And so we had people working on that from very, very early on, finding additional mask suppliers, finding companies making shields, finding the distilleries and beer manufacturers that were making hand sanitizer, all those things that we went and sourced ourselves. So that was great that we had people dedicated to that. And they were very good at it because we've been able to maintain a good supply of PPE so that our staff have adequate supplies to keep themselves safe. The other big part for us was increasing our stock of equipment. We started very early to increase all the pieces that we saw potentially having higher demand. So big things like oxygen concentrators, liquid oxygen systems, cylinders, even the soft goods like nasal cannula and tubing and all that kind of stuff. So we started to build large stocks of those. And, you know, it turned out that what we thought were large stocks weren't large stocks because they quickly got used, and we saw that we've never been out of equipment. We've been in good shape that way, but we don't have an excess of equipment. We're waiting for deliveries from the manufacturers, working with them constantly to ensure that we're still on their priority list to get us more equipment because of the demands of it. But we're only in that situation because we started early and stocked up and put ourselves in a good position working with our suppliers in the community. And a big part of that was the anticipated surge. The alternate care sites were all looking at equipment, how they were going to service those. And so there was a large demand for equipment from hospitals and areas all over the province. The other big thing, we had to change our care practice a bit. So normally our service delivery representatives perform the initial oxygen setups. They go in, set up the equipment, really focus on safety and usage with the person. That's the sole focus of the visit: get the equipment in, get it set up, make sure the person can use it safely, and they're going to be safe with it. The RTs take a much more clinical role. They come in, they review all that stuff, make sure that the person understands it, understands why those guidelines are there, but then really focuses on clinical care, their assessment, setting goals with that patient. What does that patient want to accomplish? What do they want? What things do they want to do? So with the idea of minimizing our staff exposure to the homes and the patients to caregivers, the patients don't want extra people in their houses either at this point. So we had switched so that our respiratory therapists are actually doing most of the setups now, which means you're combining a couple of the different visits into one, and then doing a lot of the follow-up, like the goal setting and things like that. You're doing that remotely after. We're trying to limit the number of visits in the home, still going in the home when we need to though, but trying to limit that. Still needing to do a clinical assessment. Our therapists are still doing an initial assessment of these people to make sure that they understand what this person, what their baseline is, where they are, so that when they're talking to them on the phone, they know what they need clinically. They can understand where they're coming from, rather than doing it all virtually because they would miss so much in that first visit. And our virtual care, it evolved quite a bit from previously. Our phone calls were just quick check-ins really, and a lot of the time they were check-ins and making an appointment to go see them in the home. Well, now they're a big part of the clinical assessment, utilizing things like Borg, MMRC, all those different tools to help us, but really looking at how we can do that over the phone more. Virtual care is still largely limited to phone calls. There have been some movements in video phone calls, but of course there's still a lot of challenges with patient privacy and things like that for us doing a lot of home visits that way, as well as the technology making sure it works effectively. Again, we're dealing with an primarily older, vulnerable population that don't necessarily do those calls as well as someone more technologically savvy might. But we're also doing virtual assessments and virtual visits on all of our clients. So we have some clients that are extremely independent. They've adapted well to being on home respiratory services. They don't want people checking in on them all the time usually, but now most of them are quite welcoming. They are happy to have someone check in on them, and if it's just a quick conversation to make sure things are going all right. And so we've implemented that for all of our teams as well. And then there's lots of reporting and tracking from different levels of government, from staff resources to PPE level. And some of those reportings that we've been required to do have been as frequent as daily for some things, that they want new counts of how many staff you have available and different things. So fortunately, most of those have tapered off a little bit to their at much more reasonable and manageable levels at this point. So the challenges, PPE donning and doffing. I said, you know, the therapists are skilled at it. Our other teams have become practiced at it, but there are all kinds of twists in that. Where do you do it when you're in the community? Do you do it at the side of the road when it's a windy or rainy day or snowing? How do you do it? So there's a few extra challenges. And then what do? There's no garbage pail sitting at the door when you're done. It's not, you don't typically get that convenience. So then you have to figure out how to manage all those things. I mentioned earlier the highly variable expectations in long-term care. Long-term care homes, we were viewed as essential visitors. They made that determination very early on. Retirement homes don't have those same rules. And so some retirement homes would welcome you in to provide the service. Others wouldn't want anybody in their homes. And so then you would have to work with them to figure out how to care for people effectively in those homes. And then people's private homes. Of course, it's their home. They make the rules. So you would have people that, again, would be very apprehensive about having anyone in their home and would ask for all kinds of things as far as PPE and procedures and different things that didn't necessarily always align with what the science was saying at the time. The other challenges we found were certain variations amongst healthcare professionals. So between, say, respiratory therapists and what the physiotherapists or occupational therapists were doing. So that was something we had to align as well, going into people's homes. And if all the healthcare professionals, so if the nurse came in and did one thing, the RT did a different thing, and the occupational therapist did yet a third thing, that wasn't very confidence inspiring for the patients. So we had to work with all those different groups that we work with in the home all the time to make sure that we were presenting a unified front so they understood, and we were all using appropriate PPE and practices to make sure that they were safe. Another thing, managing expectations at the alternate care sites. So there were some massive plans at alternate care sites that had some very, very high expectations that weren't really that feasible to achieve. Some absolutely had great plans and did some very, very smart things. So it was just working with all kinds of different groups, and they were all essentially starting from scratch. They were all trying to create their own alternate care site. And so working with them to try and support that. And then really the big focus for us was maintaining that quality care while minimizing that close contact. So again, a lot of our visits are virtual now, but as we say in the next line, not all care can be done virtually. We still have a lot of people that we need to see in the home, certainly not as frequently as we have before, but we need to do it safely for them and for our staff. CPAP, as I mentioned, polysomnography was paused as part of that order, directive number 2. And so that wasn't being done anymore. Most of the clinics have gone to only running virtual clinics or not running clinics at all. A lot of them still continue to run some virtual clinics. And so we went to the prescribers, to the physicians, asked them to identify those people that were urgent, and really only initiating CPAP if someone was screening positive that they had some kind of an ARI at the time. We weren't setting CPAP up, we were postponing that, recognizing that we needed PPE to apply pressure for these people. And so it changed the way a lot of what we did. So the setups of CPAP in the offices were greatly minimized, continues to be at this point, finding creative ways to do it, and finding, for supplies and different things like that, whether it's delivery, couriers, curbside pickup, where we're arranging things with people so that people are still getting what they need. It's just changed it significantly how it's going. And at this point, we haven't heard a timeline for when sleep labs are reopening or how they're planning to manage diagnostic studies or the titration studies. So some of that is preparing. We're looking at how we're going to manage CPAP effectively in our offices and for clients. But some of it is waiting to see when things start to move forward in that area as well. So it's a bit of a gray area, but certainly the priority dealing with those people that are urgent, that have urgent needs so they can continue with their therapy, but not much on the elective side at this point. And so now I'll hand over to Stephanie, and she can continue talking about the complex clients of ours.
Thanks, Dave. Are we okay for time, Kelly?
Yep, you're good.
Okay. So I'll try to just summarize the last 4 slides quickly. A very key role and focus for the RTs has been to taking the right actions to keeping both ourselves and our patients safe and out of hospital. Dave spoke to our RTs needing to stay current with the changing recommended screener to ensure we effectively screened each patient and household member prior to every inpatient visit. And this effectiveness allowed our RTs to make the right decisions relating to PPE, whether it was indicated and also whether it was appropriate, following the Ontario Health recommendations. Our respiratory assessments needed to be very thorough. Our RTs became the eyes and ears for respirologists and primary care practitioners in the community, being that we were one of very few providers that were performing in-person patient visits. And one example of that would be our ALS patients. Typically, when they were referred to us, they would have been assessed first at the ALS clinic and been introduced to the idea of therapies, that being cough assist, bilevel, and suction. Whereas now these patients are being seen by the respirologist virtually and then referred for in-home respiratory assessments and therapy initiation. And our RTs working very collaboratively and closely with the respirologist in titrating those therapies to the patient. We also became the frontline point of contact and resource to community respiratory patients and family members. One example of that would be a young woman who was trached. She'd been trached since she was 2 years old, reaching out for some assistance. She had become a PSW, and she needed some guidance around how to keep herself safe. So looking into a speaking valve that was compatible with the Jackson trach, and that's been a bit of a challenge due to licensing issues in Canada. And also acquiring the use of a mask that would cover her face and her neck. We have another patient who has a friend who is making these masks. And so that's been very helpful from a community perspective, and our patients have been very appreciative of that kind of collaboration in the community. Some challenges that we faced, Dave mentioned quite a few of them, but the main one would be around resistance or refusal to in-person visits by our patients. Many of the patients who are on LHIN-funded home and community care services had put their services on hold, whether that be PSW or nursing, due to the fear of contracting that virus. So our RTs needed to be very aware of how they explain things to the patient to make sure that they could alleviate the patient's concerns, making sure that they could use factual information. As Dave mentioned, there was a lot of misinformation out there that we needed to navigate, and also make sure that our patients understood that we were following the directives. And some of those things that we practiced in the home, Dave referred to as well, effective hand hygiene, auscultating the patient from the back, auscultating the chest from the back, sorry, as well as diligently cleaning the diagnostic equipment that we brought into the home, which was the stethoscope and oximeter. We had to become pretty creative in thinking of alternate ways of performing assessments and clinical interventions. One example would be assessing a child from a distance. Many parents were very fearful of having in-home respiratory therapists coming in, and also they were appreciative of the visit, and we could do a lot of the instruction and education using descriptive words rather than demonstrating by action. So we became quite adept at doing that. The other piece that Dave spoke to that was a real challenge was around donning and doffing. Dave spoke to inclement weather. Thankfully, we have hatches at the back of our vehicles to help protect from getting completely soaked when it's raining outside or when it's snowing. But one other challenge was in apartment buildings because you had to be very prepared prior to going into the home. Typically, we would bring in trait change kits with us that would have everything that we would need. So it was being very prepared going in with what you needed and only what you needed, and being able to don PPE in the hallway of an apartment building and hoping that everything that was left there was there when you left the apartment, and also setting up the garbage bag to make sure that everything could be disposed of safely at the end of your visit. So that was always quite a challenge. The other challenge that we found for this vulnerable patient population really relates to mental health. A lot of these patients were very isolated because they had put services on hold, and also they weren't going out of their homes at all. And so we had to work very closely with the LIN and the care coordinators to be able to be a liaison to be able to have access for those patients to other essential services that were outside of respiratory therapy. The other component was the fact that the ADP office closed, and so many of these patients were not able to access the grant payments that they required. But thankfully, as of April 29th, ADP announced they would start accepting application for supply grants by email, and we were working quite diligently with the physicians to get the application signed and sent into ADP so that it would expedite getting the grant payment. As far as the impact on human resources, orientation is very different now compared to before the pandemic. We do need to follow physical distancing, as Dave mentioned, during both training and orientation. So we're using a lot of case study and mock patient scenario reviews as opposed to going into patients' homes and doing the education there. We also have to use separate vehicles and minimize the use of PPE. And the other component is the training focus has really shifted, making sure that donning and doffing of PPE is a huge focus, especially for new staff that are just out of school, and using mock scenario style training done outside so that it could mimic the environment that they would be going into. And lastly, effective patient interview skills. It's really important, especially as they've mentioned, being able to assess patients over the phone, to be able to ask the right questions in order to get the right information that you need in order to make clinical decisions over the phone. And I think that's it. Did you want to speak to the link?
So yes, there's a few links at the back page. Most of them are, people are aware of them already. Everything from the RTSO to different ones. There's a couple links there. One is about sourcing equipment. It lists all different kinds of places where you can source equipment. At this point, with the started reopening, we're seeing all kinds of different healthcare providers trying to access equipment, from dentist's office to all kinds of others. So it's an interesting time to try and improve your situation if you're already short of equipment, short of PPE. Anyway.
That's amazing. Thank you, guys. So many things to think about when you're not in a building. So for anybody who does have a question, there is the question box. We have a few that have been typed in, so I will ask them now, and then we'll see as more come in. So first is from Carol Ham. She says, "Hi, Dave."
Hi, Carol. That's a question?
Well, it's got an exclamation mark, but
Okay.
sorry. There's a general comment here from Nancy Gibson. She says a general comment that vendors thank OHRSA, the Ontario Home Respiratory Services Association, working very hard with the ADP to change processes that kept our staff and patients safe. So I think you guys did touch on some of that in your presentation, actually. Akriti says, at the rehab hospital I work at, physicians are requesting overnight oximetries as sleep studies are not available. Is this something home care companies can offer? And if not, what do you recommend as the alternative?
We've been working with some physicians to prioritize a list. And again, looking at the most urgent cases. Based on Directive 2 right now, non-essential things still are not part of what we should be doing. So it's really looking at those ones that are essential. So that involves a communication with whoever the prescriber is, saying, yes, absolutely, this can wait a while, or no, we really need this information right away. We need to treat this person urgently. And then if it is urgent, then yes, we have found ways to be able to get those tests done safely for the person and our staff.
Great, thank you. The next one is from Lana. Excellent talk. Wondering if you require that your clients wear a mask during your visit, and do you provide one for them? Thank you.
So again, it depends on the circumstance of what we're doing, and if the visit comes down to that definition of close contact. If we're going to be within 6 feet of the person, and then we will look at having a mask for that person. If they can provide their own, great, because a lot of people, given all the guidelines that have been out and the reinforcement from the provincial government that people should have masks for when they're doing things. I know it's fairly recent, but they've been doing it over the last little while, and the mask encouragement's been there. A lot of people have their own, and so they can wear them. If necessary, we will provide one for people. Again, that comes down to PPE management, though. It's not usual that we do. It's usual that we're protecting our own staff, but we aren't providing a lot of equipment for the clients themselves as far as PPE.
That's fair. We have Kathleen here who's asking to see slide 15 again. She said it was up for a short period of time. Oh, it's your training? She probably wants to know who all the people are.
That's our team in Sarnia at our Lambton ProResp office. They were actually, we have, Stephanie talked a little bit about mental health with the patients. Well, we've been doing a lot of things to work with the mental health of our staff. And so we have a fun drive on our shared computer drive called Silver Linings. And so our offices were asked to do cute little videos or take pictures and things like that. And so these guys were in the midst of doing their little performance and video with their PPE at the back of their vehicles.
That's awesome. Lori, or I'm not sure if it's Lori or Lindsay or both of them together, it's kind of merged. So there's a thank you, and then Community RTs, thank you for what you're doing. And absolutely, I echo that. I know that sending patients home, knowing that we can send them home and they're still supported is a huge relief for us, and you guys go above and beyond, so thank you for that. Melissa here is asking, Melissa Trin, have you managed doing mask fittings for new CPAP users?
So that's one of the things that we have been working with, but it is difficult because it's classified as aerosol generating medical procedure. At this point, we're trying not to do it in our offices unless absolutely necessary. We're more inclined to do it in the person's home. Again, prioritizing only people that absolutely need it, and trying to do as much of the fitting without air pressure as possible. So just getting fits, adjustments, all that kind of stuff, and applying pressure. The actual goal is if we can set up the mask and then move 6 feet away, even though we've got our PPE on, get them to apply the pressure themselves. They're at home, so they should be using the system themselves anyway. So we have found some ways to do it safely, but it's not a routine thing at this point. We're still working to try and figure out how to make that more effective and be safe doing it.
To add to that, we also use a lot of resources like videos for mask fitting.
The next question is from Priya, and she's asking, could you review directive number 2? Sorry, I missed that. And I think linked into that would then be, are CPAP patients able to be seen in the office? And I'm not sure if Carol Hamp's still on here, but.
Well, the directive 2 is on that list of directives from the Chief Medical Officer of Health. So that was just the one that basically stopped all the non-essential services. So that was the same directive that stopped all the hospitals from doing elective surgeries, all that kind of stuff. So it's all built within that. And CPAP application was considered to be part of that directive because it was considered a non-essential service at that point. That, again, not every single person, there's always exceptions, but in general, that routine CPAP application was considered to be part of that. Carol may be able to have a much better answer to that, but that's essentially it for us.
Carol has typed that it is still in effect, and I will share, I was just before this on a collaboration table call with the ministry. It's still in draft what the revisions are going to be. The revisions are going to be focused, the first release of revisions will be focused on elective surgery and enabling that piece. And then there will be another release shortly after that revision that will look at other adjunctive services. So there's a lot of people asking about Directive 2 and where it's going. So you're absolutely right, it's all still fully into effect. And I will add into that, if you do have any questions, direct them to Carol Hamp, because she's managing that quite greatly, and that's who I ask all my questions to. I'm not talking with my mute on. There's a question here. Would you consider a reusable respirator for staff? Is this advisable? So I think they're thinking like the P100s with the filters versus an N95.
Well, there's, it's always an option, as most of the guidelines, again, most of the guidelines when they come out, they say N95 respirator, and they generally leave off or higher level. But a lot of the documents now have been actually stating that, partly because there's not a lot of N95s out there. But you know, a half mask respirator or anything like that would be fine. It's a challenge to wear effectively. It's a challenge to clean. And really, unless we get to the point that our supply of N95s is getting challenged, that we don't have it, we don't have prospects of replenishing it, we're not really looking at alternates right now. But who knows, that's 2 months from now or whenever, that could be changed greatly.
Thank you. And then are you wearing full PPE with every patient or just for the COVID patients?
So sorry, Stephanie, go ahead.
No, go ahead.
We're obviously changing from surgical mask to N95 for aerosol generating with in that part. But if we're going in the home at this point, we're wearing PPE. Just in our long-term care homes, they've had a universal masking protocol for a while that everyone going in the homes is masked. And so we've been adding that extra piece again, because we're going in multiple homes, so we're taking that extra step as far as safety and PPE.
Okay, that's all the questions. I do have a question, and you probably don't have an answer, but we're just tossing this around right now. Students, do you feel that you have or will be having enough supply to be supporting students accompanying you in the near future?
Yeah, we typically every summer, I'm based in London, so we I have the opportunity to be close to this project. We work with Fanshawe College and do a summer internship, which isn't really as respiratory therapy students because they're on their summer vacations. But we've been doing that every year for quite a few years now, where they spend a few weeks with an office, and then we have our regular rotation of students. At this point, we are really challenged to have students for a lot of reasons. One, the physical spacing just gets too challenging in the offices. We've got it worked out with the number of people we have in the offices and maintaining space. Adding another person into that mix challenges that. But also traveling to go see clients, we don't need to expose another person, or the clients really, as Stephanie mentioned as well, don't want additional people in their homes at this point. So we're working again, trying to figure out, because as most of you do, we enjoy having the students. It's good, it challenges us, it makes you think. And so we enjoy having the students there. But we need to figure out a way that we can do it safely. And at this point, we aren't having students in our offices, but we're hoping that we can get that figured out, hopefully by the fall when they're back in their regular school routine.
Yeah, we're having the same struggles here. So, oh, we do have, how many patients were seen in the home by RTs?
I don't know the number, Stephanie. All of our new setups, so all of our new oxygen setups are seen in the home by RTs. As to apply an actual number to it, I'm not sure what that number is. We still do visits. As I said, not everything can be done remotely or through a virtual visit, so we still have visits for those clients. And then especially in our population of people with complex respiratory needs, those on the non-invasive vents, trachs, cough assists, all that kind of stuff. We've been seeing a lot of those people relatively frequently for training of caregivers for actual clinical care. So we're still seeing quite a number, nowhere near what we would on a pre-COVID basis though.
And then
On
one
average, it's about 3 to 4 in-person visits a day in the North region anyway.
and then there is a question I accidentally skipped over, and it was, are you aware of any home care RTs, either within your organization or elsewhere, that have actually come back testing positive for COVID?
Not in our organization.
Fortunately, no. We've had quite a few tested. We've had people off for extended periods, but we haven't had anybody test positive. And I haven't heard of anyone at any other organization either, fortunately.
That's great. Okay, so we're almost at time. I'm just going to quickly flip. Actually, it's okay. I don't need to flip back to my screen. I want to thank you guys so much, and I want to thank ProRes for always supporting the RTs within Ontario and everything that we do, and for putting this together for us in a very short period of time when you're already swamped and busy. We really appreciate it. If anybody does have any questions, office@rtso.ca, you're welcome to email in at any time. Also, we will shortly be putting out something where we would like to collect either through airwaves or send it in through office@rtso. We know there's so many great initiatives going out there, and we would really like to capture them so that we can share them with everybody across the province, let everyone know of the great work. So whether it's going to be pictures, stories, whatever it is that you'd like to share, please absolutely feel free to let us know what's going on, because we know what's out there, and we would love to be able to share that with everybody. Also, the RTSO largely does depend on members, so thank you for everybody who has been supporting the RTSO in what we do. We are predominantly a volunteer organization in that we have one paid person who manages our website, and so we all do this on our spare time, and we truly believe in the work that we're doing, and we really appreciate your time, your energy, your thoughts, your suggestions, as well as your support financially to keep this organization going. So thank you, everyone. I hope that you've had a great week thus far and the rest of your week as well. And thank you again, ProRes. Dave and Stephanie, thank you so much for putting this together and for sharing your time. And I hope everyone has a great rest of the week. Take care, everybody.
Thanks, and thanks for attending, everybody.